be able to share some of the things which we all have been coming across, at least I would say pretty frequently. I'm sure everyone is using or coming across a lot of times, especially from the cardiology. We keep on asking or requesting for exercise tolerance test, isn't it? So, so one of the first question comes is, what is exercise tolerance test? Isn't it? So I think everyone understands it very well, that it is actually more of we are trying to make someone exercise, and we are trying to evaluate the cardiovascular system's response to the exercise, of course, under controlled conditions. So you're also trying to see about the cardiac perfusion, the cardiac function, and also especially in relation to the medical history, the physical examination findings as well, which is very important in exercise tolerance test. Can anyone let me know, like, what is the reason? Why do we ask for exercise tolerance test? What is the reason? What is the purpose for this? So I think most of us are already aware, as I was telling, that we try to provocate and also identify the area, for example, or if there's any presence of myocardial ischemia, and this is one of the pretty oldest tests which we all have been using. So it's not just to try to detect the coronary artery disease if someone is having a chest discomfort or chest pain, or even if you are trying to evaluate the anatomy or the functional severity of the coronary artery disease, even if you are trying to predict the cardiovascular events and the all cause death of such patients. Similarly, if there is someone for whom you want to evaluate the physical capacity and the effort tolerance, okay, and similarly, if there is someone who complains of exercise related symptoms, so what is the best way? So, is of course to make them, you know, exposed to this exercise and try to see for the various responses which may be assessed, in fact. If you're trying to look out for the chronotropic competence, or even for someone you have implanted the device therapy, and if you're trying to assess like how good is the chronotropic competence as well. And even there will be some patients, if you're trying to see for the medical intervention as well, uh, then you may assess for the exercise tolerance test. So now everyone is already a master, I would say, okay, in this topic. We all are clinicians, right? So there's a simple question for the day, and it is, this is the baseline ECG of a patient, of a someone who is exactly 35 years young. You come across, so this is the baseline ECG which is there in front of you. Your doctor, you don't have the exact details. So what had happened is, you came to know that the physiologist came to you that your consultant has asked for exercise tolerance test of this person, and you are supposed to supervise. Unfortunately, luckily, we must say we all are lucky to have very good, friendly physiologists. However, you're not able to get other clinical information. Okay, so you start. Do you notice anything abnormal on the ECG over here? Please feel free to use the chat box. See, I'll tell you one thing. No one knows everything. In fact, we all try to learn with passage of time, and this is how it goes actually anywhere. So I would suggest is, this is a good time to make mistakes and learn from it, and don't be afraid, that okay, my guess or my answer is going to be wrong, what may others may think and all. Don't think about it at all. Okay, angina. Someone says something on the V1. If you look on the V1 or V2, does it ring a bell or something? So there is something, is there? Some abnormality is there indeed, isn't it? So then what you do is you started doing the exercise tolerance test. And then in the exercise tolerance test, what happened is, what did you notice? So this is the ECG which you notice what is happening over here. So what do you think? What is happening over here? Okay, some right indications towards a positive direction. Wonderful. I appreciate it. Good. That's a good thinking. I like good guesses. Then, so during the stress test, you saw like this. Then what happens is, okay, you didn't see any much of significant STT changes, and also the physiologist says, okay, let's stop the test. So what happens is you stop the test, but after 5 minutes, what you notice is this. And then in the precordial leads, finally it comes like this. Now, anyone would like to guess what is happening? Come on. I like it. I like it. So, I'm glad that at least you are able to think in that direction. And why am I glad? Because it is important to be able to understand exercise tolerance test is not just only for ischemia or coronary artery disease. So we can even think for something else as well, provocation tests as well. So okay, there was someone said it, coving of T segments, interesting. Query some syndrome, huh? Okay, that's good. Always in life, what I learned was always have differential diagnosis. Being a medical student, that's very important to have the differential diagnosis in front of you. Okay, now coming back to our topic, what we had been thinking to learn today. So what are the types of exercises which one has to undergo whenever undergoing the ETT? So one of them is isometric exercises, in which there is a constant muscular contraction without any movement. So for example, like the hand grip, it tends to impose a disproportionate pressure load on the left ventricle relative to the body's ability to supply oxygen. Okay, so one side is the isometric exercise, the other side is the dynamic exercise. So dynamic exercise is defined as the rhythmic muscular activity resulting in movement that initiates a more appropriate increase in the cardiac output and oxygen exchange. So now, after knowing this, so what is happening is we all should be able to understand what is happening in the exercise physiology. So in the exercise physiology, there are two components. One component is the sympathetic activation. So with the sympathetic activation and parasympathetic withdrawal, what do we start noticing is there will be vasoconstriction except in exercising muscles, cerebral circulation, coronary circulation. Then there's also norepinephrine and renin level is going to increase. And oxygen extraction can go as high as almost 3 times. The ventricular contractility is going to start increasing as well. The peripheral resistance will come down. And as you may know, the systolic blood pressure will raise, the mean blood pressure will raise, even the pulse pressure will also raise as well. Any guesses what happens about the diastolic blood pressure? what is happening, what tends to happen, especially for the diastolic blood pressure? Come on, systolic, I said it definitely goes up. Mean blood pressure goes up. Pulse pressure goes up. The diastolic, okay. So what happens? There may not be much of, yes. So what will happen is there may not be much of significant changes. So that's why, as I was telling you, uh, on an overall basis, what happens is that, as you can already see in the graph beautifully, the cardiac output is going to increase at least 4 to 6 times, in fact. And as you know, the pulmonary vascular bed can accommodate at least up to 6 folds of the cardiac output. So, what is metabolic equivalence? Does it ring a bell? Ding, 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 ding. So, what is metabolic equivalence? This is a wonderful term, what we call it as, especially in the exercise tolerance test, 1 MET. Okay, so 1 MET is like the basal rate. So, this is the aerobic oxygen consumption to stay alive. So, which is, well, how much is the normal value? So, this can be an easy question, as I said it, especially for the MRCP or later on as well, if someone is planning to be a board certified, cardiologist, if someone is trying to practice in other countries as well, they will be asking such kind of questions. So how much is 1 MET? 1 MET is 3.5 ml of oxygen per kg per minute. So as I already gave you an example, like in resting, 1 MET is there. So if someone is on level walking at 2 miles per hour, how many METs do you think will it be? So at 2 miles per hour is 2 METs. At 4 miles per hour is 4 METs. Okay. And then if, for example, if someone's exercise, we commented like is less than 5 METs, so it's actually poor prognosis. Okay. The 10 minutes. So what happens is, even if someone may be having a blockage, okay, so you have seen the blockage is like 70%, 80% and all. However, if someone is able to go up to 10 METs, so the medical therapy will be as good as any kind of coronary artery bypass surgery as well, or any kind of interventional procedure as well. So imagine, this is such a powerful test that with this test you are able to prove that medical therapy will be almost as good as the surgery, so no need for any intervention procedure as well. Of course there's a slight trick to that. As I said, it is, yes, if you notice there is a nuclear perfusion defect, then you must intervene, in fact. And 13 METs, excellent prognosis, whatever, even if there was ST elevation in between, or if one is able to cross 13 METs, nothing needs to be done at all. Okay? Wonderful. So I think you all will agree with me is uh, we all tend to change in the passage of life. So for example, if someone is a bit younger, the heart rate, the maximum heart rate can be slightly different, because the amount of exercise which one will be able to tolerate will be different compared to someone who is in their 50s, isn't it? So that's why there's a term called as age predicted maximum heart rate. So, how do we calculate that? So, we calculate by reducing 220 minus age in years. Okay, target heart rate is the 85% of the maximum predicted heart rate. So, okay, so if someone is able to go up to 100 is pretty fine, but up to 85% is pretty good as well. And as I was already telling, the maximum heart rate definitely tends to come down with age, and yes, it should not always be used as an indicator for maximum exertion in the exercise tolerance test. Okay, so Now we are sure about the indications. What about relative contraindications? Anyone would like to comment about it? So we know, like, okay, when we should do this test, but what about when we should not do, when we should be avoiding? So what happens is, if we all have come across, like, there's a left main blockage, there's a left main obstruction. Otherwise, if someone is having already a tachycardia or tachyarrhythmia, in fact, and which can even lead to hemodynamic compromise as well. And similarly, if there's a acquired complete heart block, so definitely those kind of patients you should try to avoid it. In fact, and then what will happen is, if you all are aware that there is a patient, whose blood pressure is quite a lot high, so definitely that is one of the times I would really suggest you all to avoid such kind of testing. Yes, testing is important, but not at the risk of putting someone into danger. You're trying to help a patient. You're not trying to, endanger someone. ST elevation less than 1. No. Nope, nope, nope. Okay. And similarly, if there are some uncorrected medical conditions, like if someone is having anemia is there, there's electrolyte imbalances there. Otherwise, similarly, if someone is having hyperthyroidism as well, okay? So that is also, I would say, one condition in which I would like it to be avoided. So once you are aware of the relative contraindication, what about the absolute? So relative contraindications, you can still think. Okay, good, 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 Sean. I like your answer. That's what. Now we are going to come across the absolute contraindications. So even in this, wonderful, very good, very good. As you already said it. So similarly, if there is someone who has had a heart attack within like 48 hours, or like if someone is still having an ongoing chest pain, unstable angina, otherwise the cardiac arrhythmias, if I said it, then if you suspect an active endocarditis, or someone already said aortic stenosis. So if it is going to be mild aortic stenosis, can I expose the patient for the test or not? So what do you think? Can we expose the patient for the test or not? Yeah? Please use the chat box. So, mild aortic stenosis is not a contraindication, I would say. A lot of times we do try to have the functional capacity assessment as well. So, mild aortic stenosis, no. I would say, but if it is severe aortic stenosis, then yes, you have to. Then, as I had already said it to you about, if someone is having a decompensated heart failure, otherwise, if you suspect pulmonary embolism as well, or even the cases of acute myocarditis or pericarditis, if you're suspecting, or aortic dissection as well, or even, of course, if someone is physically disabled as well, and so that those are definitely the people you must not expose them. Okay, good. So now you are even super smart. You all are aware of the absolute contraindications as well. How do we do it? So now we have a good understanding of the theoretical background of such patients. So how do we do it now? So what are the different methodologies? So okay, what are the different ways of doing it? So what happens is, today in today's world, when we are talking, it is quite a lot safe. I would say like less than one in a thousand or one in 10,000 tests only tend to become complicated, even compared to like 20 years ago. So in 20 years, the test has become much more safer. We all are much more experienced, and in fact, the equipments are available easily. Expertise is available easy. So now you are thinking of planning up a test. Okay, what are the equipments which will be needed, you think, to do a good exercise testing? So you are made in charge of the exercise ETT room. You are the boss. So what are the things you will try to make sure? Come on, as a clinician, what do you think? What are the stuff you will be needing to have a good ETT? Otherwise, you are thinking of starting up your own clinic, huh? Private clinic. So you have to start thinking about that. Good, wonderful. Treadmill, ECG, BP machine. Okay, what else? Come on, think beyond. Think afresh. If something goes wrong, what else you may need? See, there are two type of people. One is someone who commit a mistake and then learn, and there are other group of people before committing a mistake they will learn. So that's what is real smartness. To be able to anticipate what may happen. Okay, good. Recess trolley, crash trolley. Good, good. What else? Defibrillator. The resuscitation equipment should be there, right? And of course, your stats. Don't forget that, right? So you all have to be really a bit cautious. So now you got this patient, you got all the equipments and all. Uh, you have now you're almost ready. Okay, so before taking the patient for the test, what are the preparations you will do? Come on, think sensible. One of the things I learned in the early days of medicine was rare things are rarely correct, common things are commonly correct. So think common. So if you are supposed to make someone run, what are the pre-test preparations you will try to ensure? Wonderful, wonderful. Good, good. I like it. Wonderful, good. Blood sugar, blood glucose levels for diabetics, observations, good. What else? So you should at least instruct them not to eat, drink, or even smoke at least 2 hours prior to the test. Okay, and of course they should be dressed comfortably. Yeah. Explain to patient. I learned it in the early days of medicine was well informed consent. Any kind of procedure if you're trying to do, even if for putting up an IV line as well, well informed consent is always important. Okay, so something like ETT for sure you have to get a well informed consent as well. Then ensure there's a proper footwear, and also try to go through the medical history as well, what kind of medicines you are trying to take as well. Make sure you are able to also rule out any increased risk of testing. So, for example, as we already discussed about the relative contraindications, absolute contraindications, and do a physical examination, a quick one at least, about a systolic murmur if you come across, or any, you know, try to rule out some murmurs as well. And yes, as our smart audience, as someone said it, a 12 lead ECG, isn't it? And then, of course, you try to do is a good skin preparation, isn't it? Otherwise, what is going to happen is you will be getting a lot of artifacts, the contact will not be good, and also what is going to happen is due to the resistance and the tendency towards the contact noise, the quality of ECG you are going to get is will be terrible. So you should try to shave at least in the areas and rub it with alcohol saturated gauze. Try to ideally use a disposable electrode, okay? And what will happen is, yeah, you can try to minimize the exercise electrode placement by keeping the armed electrodes off the chest, okay, and keeping them on the shoulders. So, for example, rather than the electrodes from the chest hanging down, keep it onto the shoulder or to some support rather than, because otherwise it will be able to fall. So, I think everyone is already a master, okay? Otherwise, I would have loved to ask, like, where do you keep these electrodes and all? And a lot of times, it can be a bit tricky, okay? So once you know where to keep your leads, you have kept these leads and all, okay? And try to make sure that there's a good quality reading is there, and then finally you start the test. So now, during the test, what are you going to do? What do you do during the test? Come on, think. Be a bit more creative. Being in medicine, you should always master the questions. So always ask anything: who, why, how, what, when. More is the number of questions you ask, more you will know it better. So during the test, what will you ensure? So you will try to make sure you're monitoring the ECG recording well, blood pressure at regular intervals. Of course, encourage the patient, try to have a good rapport with the patient so that at any moment the patient feels anything and all, they will always share the symptoms and also the fatigue. And you have to also keep on looking at the patient, okay? That is the patient looking comfortable? Is the patient looking, not comfortable, annoyed, or not, is he feeling any pain or something as well? So that's very important. And yes, as we already emphasized, target heart rate based on age should not be used to terminate the test, because the relationship between the maximum heart rate and age is poor. And for the test termination, as I had already said it, the absolute contraindications and the relative contraindications, which we already discussed, that's what you should be using. So, now you did all the tests and all, okay, it is going on, going on, going on. Now you have become very smart, you are taking measurements, and all of a sudden you see something. And then you tell to your physiologist, let's stop it. I'm not going to do any further EGT. So what are the indications? When will you stop the test? Come on, you are already doing some measurements, right? So make a guess. So what did you observe? Something that you have to stop the test. You are a clinician, so there will be some signs, there will be some symptoms, and there will be some observations. So the first thing is, like, if there is a ST elevation, and the significant one is more than 1 millimeter. Okay, wonderful, Sean. Very good, very good. So if there is a ST elevation of more than 1 millimeter in the leads without pre-existing Q waves, okay, because of the prior MI or something like that, then other parameter. Okay, good. Drop in systolic blood pressure, more than 10 millimeters of mercury, in spite of increase in the workload. Okay. Then similarly, what about the clinical signs? As Sean Trussell already said it. If there is moderate to severe angina, then CNS, central nervous system symptoms, like someone starts to develop ataxia, someone is having dizziness or near syncope, or there is signs of poor perfusion. Poor perfusion means? Poor perfusion is like if you come across dizziness is there, if there's syncope, cyanosis if you come across The patient is developing pale. What will you do? Immediately stop it. There's no need to wait and all. You should always remember, let's not forget the basic principles of medicine. Let's not do any harm to the patient. So you should immediately stop it. Similarly, if you come across, sustained VT or second or third degree of AV block, immediately you should be stopping it. And then, as I was already telling you, what will you do if you come across the ST elevation is pretty significant? And we already said as well, the blood pressure is significantly high as well for such kind of patients. If there is a drop in systolic blood pressure, even if more than 10 millimeters, symptoms like if someone is really, the patient is telling, I want to stop, you have to stop. There's no, uh, th- there should be no second thoughts about that. Okay, similarly, if what is called as an exaggerated hypertensive response. So systolic blood pressure is more than 250 millimeters of mercury, or the diastolic blood pressure is more than 115 millimeters of mercury. Or similarly, if you come across a bundle branch block, okay, which must be distinguished from the ventricular tachycardia, yeah. So you can try to evaluate using the Borg scale as well. And yes, so Borg scale is actually an excellent mean of quantifying an individual's effort. In general, Borg scale rating is like more than 18 indicates patient has performed maximal exercise. So recovery is important, isn't it? So what has happened is when the patients exhibit ST segment elevation, okay, it can be associated with dangerous arrhythmia or infarction. So whenever there is a patient with an ischemic cardiomyopathy exhibits, or you know, they have severe chest pain, it could be secondary to ischemia as well. Similarly, if there's a patient who develops exertional hypertension, accompanied by ischemia, it may be due to even the underlying history of congestive heart failure as well. Similarly, when there is a patient with history of sudden cardiac death or collapse during the exercise, if the patient develops PVCs, premature ventricular complexes as well, then that is one of the time you must give them some time to recovery as well. So you should stop the exercise. You start to monitor the patient at least for 5 minutes after the exercise. Okay, till the time either the changes seems to stabilize. Okay, and then you even during the recovery, what will happen is you continue to monitor the ST segment changes. Yeah. So what will happen is ST depression at the time has a very important implication regarding the presence and severity of the coronary artery disease. A cool down walk can be helpful in performing tests on the patients with an established diagnosis undergoing testing for diagnostic regions. For example, if you're trying to test an athlete or patient with congestive heart failure, valvular heart disease, or with recent history of myocardial infarction. So there are various exercise protocols which is available. Can anyone recall what are the protocols which we all come across? So the most commonly used is Bruce protocol. There are other ones as well, McHenry, Norton. So in 1949 by Robert A. Bruce, which is said to be the father of exercise physiology. So he made a standardized protocol which is considered as a gold standard for detection of myocardial ischemia whenever the risk stratification is important. As you may see, so this is a bit detailed example commenting about the protocols, the stages, and also the predicted oxygen cost for the different stages. So one of the common things, what happens is, okay, so this is the typical Bruce protocol, what will be happening is you can also add a slope, at how much slope, how much miles per hour, how many minutes did you enroll, and what were the different stages over here, if you may notice. So one of the important things for us is, when do we call a test as positive test? Isn't it? That's what we all are important. We all are concerned to know. Okay, when is it positive? So when would you consider it as positive? So there are various parameters. So for example, on the basis of ST segment changes. So ST segment changes, if you may notice beautifully over here, changes in the level of ST segment comprises the earliest abnormal finding in the history of exercise testing and have been the focus of standard test criteria for the diagnosis of myocardial ischemia for like more than a half century. So as you may notice, so there are various changes which one may come across, and for those kind of tests, these changes, you must stop the changes. Okay, you must stop, terminate the changes. So regarding the ST depression, so some of the simple things is like, at least it should be bigger than minimum, at least more than 1 millimeter. If there is a ST depression, or so even in that there are okay, I'll show you some example. So this is the normal ST segment, if you may notice over here. So what is happening is over here, okay, during the exercise, this there is ST depression. But if we look carefully over here, the only the J point, only the J point is depressed. So there are three types of ST segment depressions which we all may come across. So what is something is called as a upsloping, horizontal, and then comes the downsloping. So the if only the J point is depressed, it will be still considered as a negative. However, if it is upsloping's prognosis is much better, I would say. So this is called as equivocal. However, if it is horizontal or depression of the ST segment, it is definitely positive. I hope with this figures, now there should be no doubts to anyone, in fact. Okay, what about those post-infarction patients, and if you come across a ST elevation with Q waves? So exercise-induced elevation can occur in an infarct area where prior Q waves are present. The development of more than 0.10 millivolt of J point elevation at 60 milliseconds after the J point is considered abnormal response. So not immediately, but after at least more than 1 millimeter is considered abnormal, especially if there is a prior Q wave, in fact. Okay? Then, ST segment elevation, if there's no prior infarct. So what happens is, in the subjects with prior infarction with absence of Q waves, ST segment elevation during the exercise frequently localizes the site of severe transient combined endocardial and subepicardial ischemia, which tends to cause significant subtotal proximal occlusive coronary artery disease. Okay? Then what about the ST segment normalization? Can we ignore this? So it tends to be actually for the young patients with early repolarization. They need to have normalization of the resting ST segment elevation during exercise. And normalization of the ST segment during exercise might be related to cancellation effects of the oppositely directed forces from multiple areas of ischemia. Okay? So, what to do if someone is complaining of chest pain? So, chest pain, yes, you will be alerted. But you have to always consider if the patient is having any ST depression, if there is any ST segment changes, and yes, if there is any ST depression, 85% of those times they may be having a associated cardiac disease, or I would say coronary artery disease, in fact. So during the test, if you come across R wave voltage increase, so actually this is the smallest, and what happens is like later on, if it returns back to the normal during the recovery. So what will happen is it is caused due to the reduction of the LV in diastolic volume with increasing exercise in the normal patient. However, in patients with coronary artery disease, the R wave voltage usually remains unchanged or increases, especially in those patients with a poor LV function. Okay? However, if there is a patient with a left bundle branch block, it may not change much. So, especially if someone is having a left bundle branch block, exercise doing a ETT may not be of much of use. In fact, I would say. So, similarly, what about the abnormal systolic blood pressure response? So, the failure of the systolic blood pressure on rise during exercise is an important indicator of an abnormal left ventricle and is also an indication to stop the test. And in fact, if there is decrease in the systolic blood pressure, as I had already said it, severe coronary artery disease, immediately stop the test. Okay? And of course, on that, during that time, you have ruled out there's no valve lesion and the patients are not on vasodilators as well. So, what to do if you come across ventricular arrhythmias? So what happens is the ventricular ectopics, if at least you come across more than 10 per minutes, or the multifocal ectopic ventricular tachycardia, they are very specific. And you must investigate those patients in an exhaustive way. Okay? So, uh, see, a lot of times exercise tolerance tests, as I was telling you, a lot of people may undermine it like, what is this? There's not much of use and all. But it can be quite a lot important. So, what are the things, if you come across a test that you will be thinking that, okay, this patient definitely has a multi-vessel coronary artery disease or even a poor prognosis? Sorry. Anyone? So what happens is if there is a significant ST depression. Similarly, if there is a downsloping persistent changes are there even into the recovery, then the blood pressure, there was fall of the blood pressure during the exercise, and the exercise tolerance has been quite a lot poor. Or like at the stage two itself, if the patient says like, no, I cannot do the test as well. So this is something very important. I think we should not forget. We should keep it in our brain for long, long time. So now we have understood. Okay, so what are the patients which would need our attention in a big way? But similarly, a lot of times, like any other test as well, there could be false positive tests as well. So, what are those patients which will be having the false positive? As you can already see, a lot of those patients with hyperventilation, if there's a prolapse of the mitral valve, then if there's dilated cardiomyopathy, or if with pre-existing left bundle branch block as well, or with accessory. Okay, one more relevant question. When can we expose a patient of accessory pathway for exercise tolerance test? Come on. We have a very smart audience. That's what I was said. When do we do it for such patients? To give you an example, on the basis of that, electrophysiologists, the heart rhythm doctors, can even make it out whether to do an ablation procedure or not. So, for example, if you expose someone for exercising ETT, and on the ETT, if you notice that the pre-excitation is gone, so it means there's no need for considering for the ablation procedure for the patient. Okay? So imagine, so as I said it like few decades back, a lot of centers who are not having the cath lab, the facilities for doing coronary angiogram, so they were all dependent on the exercise tolerance test, in fact, especially for to determine the prognosis, the morbidity of the patient as well. So after you have done a good test, you must always report that test on parameters, trying to give the information about the diagnosis, prognosis, how did the patient have any symptoms like the fatigue, how was the recovery heart rate, the resting heart rate, the exercise heart rate, and the ECG changes. There were, how about the capacity in terms of meds, which we spoke about, and of course at the end you also tell about the recovery stage. So during recovery stage, what happened, and after that, of course, you try to give an overall picture. Was it positive, negative, or non-conclusive? Okay. So, so we have already spoken in detail about the prognostic utilization. So it is indeed very important. You can also give what is called as a Duke treadmill score. Okay, it's a simple arithmetic formula, and if someone's score is +5, it will be considered as low risk. However, if someone's risk is -11, for example, okay, as you can see, the person will be having a very high mortality rate. So this was the picture as I was telling you. This is how you try to look on the age and double product adjusted Duke treadmill test. So what is called as DTS nomogram for the prediction of the cardiovascular mortality. It's a very summarized picture. I think you all will need to go through that in detail. So this is how finally it can be done. So how many, you know, the patient went for how many mets, and then how much was the exercise tolerance, then how much time did it take, and the exercise, was there any changes as well, okay? And as I was already telling is there are a lot of benefits as well. If someone has had a myocardial infarction, so pre-discharge, or even you try to see uh, uh, on a pre-discharge submaximal test, you try to do to try to optimize the discharge. If you're thinking of altering the medical therapy or triaging for the intensity of follow-up, or because a lot of times it happens, the family members of the patient may be quite a lot worried that is my family member good or not. What about the risk stratification and all? So it can be quite a lot important and very useful as well on these parameters. So yes, uh, even secondary to exercise testing as well, there can be complications which could be associated. So on an overall basis, we try to divide them in three ways: cardiac complications like the bradycardias, tachycardias, acute coronary syndrome, hypertension, syncope, and all, or even death can happen. Rarely, I would say, 1 in a 10,000, in fact, or even lesser. So, what about the non cardiac, like musculoskeletal trauma, soft tissue injury, or even sometimes there can be severe fatigue as well? Okay, otherwise, dizziness or body ache can also be there. So, now coming back to our clinical case. So, Does it ring a bell now? Now let's try to listen to everyone. What is happening over here? So this is indeed Brugada syndrome. So exercise tolerance test, everyone knows. Yes, we use it for myocardial ischemia to think about the coronary artery disease, but even for, as I said, it for example, accessory pathway patient, we can do as well. If you want to even similarly sometimes think for Brugada syndrome and all as well, you can think for this as well. So I'll not try to go into too much details uh, about the Brugada syndrome. Of course, we all can discuss in some other session later on for the sake of time. So this is another patient. I'll give you some example. So what was happening is, this is the baseline, V1 to V6. Okay? If you can see it well, this is the baseline over here. This is patient A. After the exercise, he developed this. And this is patient B. Figure 3 shows the patient developed during the recovery like this. What will you do? And for which one will you be getting worried? Okay. Just tell me, does both of them need attention? Yes, no? You all should be masters in ECG, I would say, by now. Because we all tend to depend on your eyes, what you're going to see in the ER or even in the wards as well. I'll like to trust you guys. So what is happening in this ECG? Okay, simple thing. There is a bundle branch block. The QRS has become wider, right? It was a narrow QRS, now it has become wider. The heart rate has not gone up, but there is a bundle branch block development. Isn't it? V1 to V6. What do you notice? So V1 over here, what is happening? So if V1, if you look for the third patient, it is R, S, R dash pattern, isn't it? So R dash pattern in V1 will be showing what type of bundle branch block? Okay, I can understand the confusion for everyone and all. Let me try to make it all easier for you all, okay? From today onwards, you will never forget about this principle. So, I will give you guys a mnemonic. Wonderful, good. Someone, oh, great, good. So, in simple words, what will happen is marrow and rabbit. So, if you come across a M in V1, marrow, and so positive, so M, this is M, and this is like W-ish pattern, marrow. So it will be right bundle branch block. Then something is called as William. William is W pattern in V1 and M pattern in V6. So this will be like a left bundle branch block. But I want to emphasize this, try to just take it as a mnemonic. It's not like, you should be able to tell it, I notice R, S, R dash pattern in V1 and Q, R, S pattern in V6. That's why it is a right bundle branch block. Yeah? So that's how you should describe it. But this was just for mnemonic. Okay, good. Wonderful. Good, someone has already given an answer that we should be getting more worried about the left bundle branch block. And why is that? So what happens is, most of the times, the area which is getting covered with the left bundle branch is an extensive area, huge area. It will be uh, prognostic for not just coronary artery disease, and it will be getting affected in a huge area, in fact, as well. So sometimes later in our next sessions we can discuss about it as well in later stages. So now you all are very much aware, now you all are very much able to understand. So a lot of times everyone says, everyone would like to pass a test, isn't it? But I think especially in the COVID pandemic, after the COVID pandemic, there are a few more tests we, in which we would like to fail, isn't it? So even we would like to fail in the COVID, not only exercise tolerance test, but also for the COVID test as well. Okay, wonderful, good, good. So are there any